Good afternoon, guys. I've got discussion A for you. We are discussing hospital delirium. Okay, which for some folks is a real problem. So I'm going to go through that for you for today's A. So please join me in the discussion for hospital delirium. Okay, here we go. Hospital delirium is not just temporary confusion. It's a powerful clinical warning sign that an older adult's whole system is under strain. A major University of Queensland study reveals that even one episode of delirium during a hospital stay can echo through the body long after the moment of confusion has passed, reshaping a person's health trajectory in ways families and clinicians can't afford to overlook. Delirium has always been recognized as unsettling. The sudden uh, disorientation and the aggression, the agitation, the hallucinations, the way a familiar face becomes unfamiliar. But this research reframes delirium as something far more consequential. A marker of deep psychological stress, a signal that multiple organ systems are vulnerable, and a predictor of serious complications that may unfold months or even years after discharge. What the study found, drawing on nearly 30,000 older adults followed over 26 years, researchers uncovered a pattern that is both shrinking and sobering. A single delirium episode was associated with falls and urinary incontinence risk doubled. Pneumonia, sepsis, fractures, stroke, acute kidney injury, pressure injuries, 50 to 70% higher risk. Gastrointestinal bleeding and heart failure, 20 to 30% higher risk. These findings held true even after adjusting for frailty and pre-existing dementia, which means delirium isn't just a symptom of decline. It is an independent predictor of failure of future health. Crisis. In other words, delirium is not merely a byproduct of illness. It is a clinical event with its own long tall long tail of consequences. The scale of the study also underscores how common delirium is. Up to 1 in 4 older adults experience it during hospitalization, yet, yet its long term impacts have historically been underestimated or dismissed as temporary. Why delirium matters beyond the hospital. Delirium often emerges from a perfect storm of stressors, infection, surgery, unmanaged pain, dehydration, medication interactions, sleep disruption, or the sensory overload of hospital environments. These triggers may resolve, but the body's response to them leaves a lasting imprint. The study reframes delirium as a red flag of multi-system decline, a sign that the brain and body have been pushed to a threshold where resilience is compromised. Even when the confusion clears, the under the underlying vulnerability remains. This is why experts argue that delirium should prompt structured follow-up, not just not just in the days after discharge, but in the weeks and months that follow. It's a call to shift delirium from a short-term hospital concern to a long-term care priority. What this means for families and caregivers. For caregivers, delirium is not just an episode to get through, it's a turning point. The period after discharge becomes a critical window for stabilizing health and preventing further decline. The study suggests delirium signals long term vulnerability, not just a temporary setback. Up to half of delirium cases may be preventable with better hospital practices, such as minimizing sedatives, ensuring hydration, supporting mobility, and maintaining sleep-wake cycles. Families should families should advocate for medication reviews to eliminate drugs that increase delirium risk. mobility and strength support to reduce falls, hydration and nutrition plans, cognitive monitoring to catch subtle changes early. Caregivers often notice the earliest signs of trouble: a new hesitation when walking, a shift in personality, a change in sleep patterns, and their observations can be crucial for timely interventions. The big picture. Delirium doesn't delirium doesn't exist in isolation. Other research shows it is linked to future dementia risk. Adults who were cognitively healthy before, before hospitalization, this positions delirium as a major inf- inflection point, a moment when the trajectory of aging can shift sharply. For clinicians, this means delirium should trigger proactive planning. For families, it means paying close attention to recovery patterns. For communities, it means recognizing delirium as a public health issue, not just a hospital problem. Delirium in the long term care challenge for clinicians and researchers. The negative outcomes related to delirium, a scoping review. What the paper did. This scoping review searched Medline, Embase, and the web for science research date May 2025 or 2025 to identify studies that examined adverse outcomes of delirium among residents of long-term care facilities. The authors followed Joanna Briggs Institute methodology and Prisma SCR reporting. Key findings, scope of evidence. The review included 14 studies that met inclusion criteria with follow-up ranging from 1 week to 2 years. Assessment methods varied. Delirium was identified using multiple instruments, DSM-based algorithms, confusion assessment method or CAM, short CAM, etc., producing heterogeneity. In case assessment, consistent adverse outcomes across studies, delirium and LTC was associated with increased mortality, cognitive decline, falls, and disorientation in activities of daily living. These associations mirror findings from hospital-based lectures showing worse long-term outcomes after delirium. Heterogeneity limits synthesis. Differences in study design, delirium definitions, outcome measures, and follow-up intervals, limited pooling, and made direct comparison difficult. Databases researched or databases searched. Medline, Embase, Web of Science, May 2025. Inclusion studies reporting outcomes after delirium among residents. Outcome measures varied and included mortality, cognitive tests, or dementia incidence. ADL scales, falls, hospital readmissions, and physical function. Clinical implications. Delirium matters in LTC. Even outside acute hospitals, delirium predicts serious downstream harms, death, functional, and cognitive decline. So detection and prevention in LTC should be prioritized. Screening and training. Routine use of validated screening tools, e.g. CAM, 4AT, and staff education may reduce under recognition and enable earlier intervention. Care planning. When delirium occurs, anticipate and monitor for accelerated functional decline and increased care needs. Incorporate this into discharge, transition, and advanced care planning. Research gaps and recommendations needed for higher quality LTC studies. The evidence base is small and heterogeneous. Large prospective cohort studies and trials conducted specifically in LTC populations are needed. Standardized measures. Use consistent delirium case definitions. And core outcome sets. Mortality, validated cognitive measures, ADL scales, falls to enable pooling and meta-analysis, larger follow-up and adjustments. Studies should include longer follow-up and adjust for baseline frailty, dementia, and comorbidity to clarify independent effects of delirium. Quick takeaway: delirium among LTC residents, it is linked to meaningful negative outcomes similar to those seen after hospital delirium, but the LTC evidence is limited and methodologically verified. Improving detection, standardizing outcome measurements, and conducting targeted LTC research are prioritized for clinicians and investigators. Article summary: delirium in nursing homes and long-term care facilities. Findings of a scoping review of detection tools. What the review did: the authors mapped the literature on structured delirium detection tools used in nursing homes and long-term care settings, focusing on which instruments are used and what psychometric evidence exists for those tools. Methods: scope researches of multiple databases, Medline, Embase, hold on guys, next page. Inclusion: original impartial studies reporting use of validation of delirium detection instruments in NIH LTC populations. Key findings: numbers of studies and tools. Review included 58 studies and identified 25 distinct delirium detection tools used in NIH and LTC research. Most frequently used instruments. Variants of the confusion assessment method, or CAM, long term or long form, short form, long form, short form. Nursing home adaptations were the most commonly applied tools. Best performing tools in LTC validation work. The delirium observation screening scale, or DOSS 13, showed the highest diagnostic accuracy in the LTC validation study. The delirium diagnostic tool, provisional or DDT Pro, achieved strong sensitivity, specifically while using very few items. The 4AT also demonstrated good specificity and AUC in available studies. Limited validation overall. Only 14 tools had undergone validity and reliability testing, specifically in NHLTC settings, leaving many instruments unvalidated for this environment. Domain coverage. 10 tools showed concordance across the three core delirium domains: cognition, higher level of thinking, circadian alertness, and important property when distinguishing delirium from dementia. Clinical implications. Prioritize validated tools. Use instruments with LTC validation. For example, DOSS, DDT Pro, and 4AT when implementing routine screening to improve detection accuracy. Staff training and workflow integration. Screening is only effective if staff are trained and tools are feasible within daily workflows. The review highlights the need for implementation strategies tailored to NIH, LTC staffing, and case mix. Watch for delirium superimposed on dementia. Tools that explicitly assess attention fluctuation and circadian disturbances help distinguish delirium from baseline cognitive impairment. Research gaps in recommendations. More LTC specific validation. Validate commonly used tools across diverse NHLTC populations and care models. Standardize core outcomes and reporting. Use consistent cutoffs. Reference standards and reporting of sensitivity specifically to allow comparison and meta-analysis. Implementation research. Study how to integrate screening into routine care, including training, frequency of assessment, and linkage to prevention management pathways. Quick takeaway. There are many delirium detection tools used in nursing homes and LTC, but only a subset have been validated. That in that setting, DOSS, DDT Pro, and 4AT emerge as promising options for implementing validated, feasible screening plus staff training is a practical first step to improve delirium recognition in NHLTC. Okay, guys, that's your A for today. I will be back on with B shortly after a little break. So I will see you guys in a few minutes for B. Until then, Gator Wellness, take care, folks.